All right, all right, all right. Welcome to another episode of the Prescription for Better Living podcast. My name is Dr. Hernando Carter, board certified internal medicine physician, your primary care extraordinaire. And this is the Prescription for Better Living podcast where we cover all things health and wellness in a hip and relatable way. Here at Prescription for Better Living, our mission is to promote health equity and eliminate health disparities by making sure you have the information and knowledge that you need. So, in previous episodes, we have begun to talk about the various care models that exist, and we were talking about concierge medicine. So, if you have never heard of concierge medicine or you want to learn more about it, you've been considering it or don't know if you should, please check out those episodes. Also, please be sure to go in, like, comment on those episodes, ask questions because we are responsive and interactive, and I'll be able to respond to you and get you the information that you need. So, with today's episode, I thought we would take the opportunity to talk about something that I do every day, and that is a type of primary care that we refer to as value based care. Value based care. What is value based care? Well, remember we talked about what the traditional practice model is, and that's what we call fee for service, meaning that every time you see the doctor, every time you have a procedure done, there is a charge or a bill that's generated. And typically, your insurance is billed, the doctor receives a payment that we call reimbursement. Sometimes you may have a portion of that charge that you have to pay, and we would call that a copay and or deductible. That's what we call the fee for service. And remember that we said in the fee for service, in order for a practice to remain sustainable, there's a certain volume that you have to have, a certain number of patients that you have to have on your books, and a certain number of patients per day that you are really expected to see just to be able to pay your staff, pay the bills, keep the lights on, even before you bring home a salary. And that's fee for service. And the majority of the American healthcare system operates on a fee for service model. And I would dare to say that if you have gone to the doctor recently, you were seeing someone who is practicing in the fee for service model. Some of the drawbacks of a fee for service model is that the fee for service model is driven by volume in terms of, again, the number of patient encounters you have, the number of procedures that you do. The more you see, the more patients you have, the more procedures you do, the more you're reimbursed. Well, why is that a disadvantage? Well, we've talked about long wait times, we've talked about limited access, we've talked about shorter visits, not enough time with your doctor. We talked about having to utilize the emergency room a lot when you really should not have to. We talked about burnout. We talked about burnout on behalf of the provider. So, doctors, nurse practitioners, physician assistants are becoming burned out because they are often stretched to the max during their average workday. But we also talked about patient burnout, right? Patients becoming more and more frustrated with long waits, short time with the doctor, inability to access their doctor when they need to, the difficulty with finding a new primary care doctor, and the long waits related to that. And those are all symptoms of the fee for service model. So, what is value based care? Well, value based care says something different. Value based care says that you will not be paid or reimbursed based off of necessarily the number of patients that you see, but you will be paid or reimbursed based off of your patient outcomes. In a fee for service model, you get paid no matter what happens with the patient. If you're seeing your 20, 30 patients per day, you're submitting your charges for whatever level or complexity of service that you're providing. Insurance will reimburse you for those services. Doesn't matter if the blood pressure is controlled, doesn't matter if the blood sugar is controlled, none of that. You get paid for the visit. In a value based care model, the insurance company contracts with the medical practice or the organization and says that if you take care of our members, we will pay you up front a certain amount. We call that amount a per member per month. But that's all the money that you're getting from us, nothing else. Whatever this flat rate is, that's the payment that you get. And it's up to you, medical practice or healthcare organization, to manage that money in such a way that you don't burn it all up. Well, the way to avoid burning the money up, believe it or not, is to take better care of your patients. We talked about how expensive emergency room care is. We also talked about how expensive hospitalizations are. What if your aim, what if your goal with a patient is to take care of them well enough to reduce their risk of having to go to the emergency department or cut their risk of being admitted to the hospital or reduce their risk of being diagnosed with some advanced disease, some advanced cancer, uncontrolled diabetes, and all of the sequelae of that, like neuropathy and poor circulation, which causes people to lose their feet, diabetic damage to the eyes that cause blindness. So, if you can incentivize healthcare providers, healthcare organizations to take better care of their members, then that reduces costs. And that's value based care. So, in value based care, we actually chase different numbers. It's all a numbers game. In fee for service, the numbers you're chasing is what we call your productivity. How many patients per day can you see, or how many patients per session, with each day having a morning session and an afternoon session, right? Churning numbers. Value based care is a numbers game as well. We chase numbers, but we chase different numbers. And the numbers we chase in value based care are numbers that are directly applicable to the patient. We say, what percentage of our patients have a blood pressure that is well controlled? If they have hypertension, how many of our patients have a blood pressure of below 140/90? And the larger the percentage of your patients, the better you are performing and the better you are reimbursed. Or if you have patients who are diabetic, how many of our patients, of our diabetic patients, have good control of their diabetes with their hemoglobin A1Cs being below 7? The more of your patients have that good control, the better you do financially. How many of our patients are getting their screenings, their eye exams, their prostate cancer screenings, their colon cancer screenings, their lung cancer screenings, their breast cancer screenings via mammogram? We track those numbers every month and we have goals that we want to hit. Well, the more of our patients that get those screenings, that reach those goals, the better we do financially. But not only are we doing well financially, but also the patients are doing better. Value based care models are incentivized to see their patients. to provide easy access so that if you wake up one day and you're sick, you have a cold or something's hurting, a joint or bone is hurting, you have a headache, and you could call your doctor who is in a value based care practice, odds are, if you want to come in to be seen today, they will say, yes, we have an appointment. Come in and be seen. Because we have built into our schedule reserved appointments for what we call sick visits or acute visits, same day or next day appointments. Or maybe your doctor will call you personally on the phone to talk to you to see if you, in fact, need to come into the office or do you need to go to the emergency department. By providing that access, we drive down the unneeded use of emergency departments and urgent cares. And remember, I said that I'm not implying that all emergency department visits are inappropriate. No. But what I'm saying is that emergency department visits are for emergencies and not for primary care and not for things that could be handled at primary care. It's not up to you to know what those things are. Some things are common sense, but sometimes there's nuance. But that is why you have a relationship with the primary care doctor, and that's why you call your primary care doctor first. Value based care. The explanation is really in the name value. What value are we offering to the patient by making sure that they are healthier, that they have the access that they need, that they understand the reasoning for the test or the reason for the medication? Value based care. Also, in value based care, we provide resources to our patients. Our patients will often have access to a social worker so that we can help address those social determinants of health, like food insecurity, housing insecurity, lack of transportation. We provide rides to doctor's appointments and not just to our appointments, but if you have appointments with a specialist, if you have an appointment for a mammogram and you need a ride, we'll provide that for you. Value based care. There's also a focus on education. Quite often throughout the weeks, there will be educational sessions about nutrition, about exercise. There'll be opportunities to exercise at the office, chair yoga and chair exercises. So those are some of the differences between fee for service model and a value based care model. Doctors in a value based care model will carry fewer patients. Recall when I said that I had over 2,600 patients when I was in the fee for service model. And in a typical value based care model, a primary care provider may have 3 to 700 patients, similar to the concierge numbers. But remember, patients who are a part of a value based care model aren't paying monthly or annual retainers in order to be members of that practice. They're not paying anything extra above insurance. Well, how is this all paid for? I'm glad you asked. Medicare, specifically Medicare Advantage. So, the majority of the value based care practices take care of seniors who are over 60, who are on Medicare. And if you think about it, those would typically be the people who need more time in front of the doctor because they may have more medical problems and more complex medical problems. So they may need longer visits. Those are the individuals that need more attention. So, in a value based care model, You may see your doctor every 8 weeks or every 3 months or sometimes every month, depending on what's going on with you. As opposed to in a fee for service model, most doctors can only see you every 6 months or even every 12 months. But it's in the value based care model that we understand that and we have the ability to manage you very closely, follow you very closely. So that if your blood pressure is not controlled or your blood sugar is not controlled, we can bring you into the office every week, every month if we need to, in order to really watch that blood pressure, to really help you work on it, the blood sugar, whatever the problem. So, the way this funding works is that Medicare, Center for Medicare and Medicaid Services, the government pays insurers to operate insurance plans. And in these Medicare Advantage insurance plans, these insurance companies contract with different healthcare organizations. You sign a contract to take care of any of the patients who meet the criteria who come. And then again, you are paid a lump sum or per member per month. So for every person, there's a certain dollar amount you're paid each month to manage their care. And the sicker the patient, the more complex the patient, then those patients are reimbursed at a higher rate. So you get more money per month for sicker, more complex patients because it's going to take more time and more resources in order to help them. So that is how that system works. Quite honestly, I wish that our entire healthcare system was based on value. Now, you can't have the entire healthcare system doing concierge numbers, right, in terms of numbers of patients, because we don't have enough doctors. We don't have enough healthcare providers for that. But we can get to a place where all doctors are incentivized to take better care of their patients. We can get to a place, even a fee for service model, where the doctors with the better outcomes maybe get paid better. And usually, when you talk like that, there are concerns about patient selection, which means that if you went to that kind of model for our entire healthcare system, maybe doctors would filter out or screen patients and say, this patient has this medical problem. I don't want to accept them as a patient into my practice, or maybe even, God forbid, fire patients if they have uncontrolled medical problems. That's usually the response you get when you talk about pushing the healthcare system more towards value. But there are ways you can control that and you can protect against that. Again, remember, I said that I operate in a value based care practice. And as a part of that contract, we say that we can't screen patients or filter them out based off of how sick or complex they are. As a matter of fact, I have actually been taking care of sicker patients in this value based care model than I was before the value based care model because they're the people who need it. I come across patients every day who have been going to the doctor for years, but that's all they've been doing, just going to the doctor. They have not been followed closely and they have not been managed tightly. They come in and they are sick. Sometimes they are so sick that they die before they make it back to my next 1 month follow up appointment. But they've been going to the doctor for years. Uncontrolled blood pressure, uncontrolled blood sugar, chronic kidney disease, heart failure, heart attack, stroke. But they've had insurance. They've been going to the doctor every 6 months. What does that tell you? The system is not working the way it should. And it's not because of malice or malintent on behalf of the doctors. They don't have the time, they're overloaded, but the way they're compensated does not promote value in the patient interaction. You get paid the same amount for that visit, whether the blood pressure is 120 over 80 or 180 over 100. But our healthcare outcomes in America, when you compare our healthcare outcomes to other industrialized nations, are worse. Our people are sicker and they die sooner, and we spend the most money per capita than any other industrialized nation on healthcare. To make a comparison, we spend the most on national defense in terms of our military spending, and we are the baddest something out there. Nobody wants to war with us, not really, because we spend the money. Well, we spend more money on healthcare, but our people are sicker. They're not living as long. They're more debilitated. Something's wrong. And it's not just an insurance issue. You can't fix this problem by just giving people insurance. Yes, everyone needs insurance. Yes, I want everyone to have insurance. But once you give them insurance, you have to give them access. You got to give them doctors to go to, providers to go to. And then once you give them insurance and give them a doctor or a provider to go to, then you have to ensure somehow that that doctor or provider is going to produce on the quality, the value proposition. And the only way to do that is not with a stick. You have to do it with the carrot. You have to bonus doctors who have better outcomes. You have to encourage collaboration. So, doctors who utilize an electronic health record, who are connected to a health information exchange, who have good collaboration with their colleagues and specialists, good communication, who have good patient satisfaction scores, should get paid more. So I'm not saying take anything away from other doctors. That's the stick. No, I'm saying with the carrot, incentivize and encourage doctors to do better. And we can do it, y'all. We have to, especially for my people, because however bad the healthcare outcomes are for Americans in general, it's always worse in Black and brown people. America gets a cold, black and brown people get the flu. So these are some of the ways that you reduce healthcare disparities, that you promote health equity. Again, this is Dr. Hernando Carter, your primary care extraordinaire, board certified internal medicine physician, saying, till the next time, a holla. Peace.